Improving the robustness of clinical MRI using radial sampling and compressed sensing. This is the transcription of a lecture that I gave at the 2014 KSMRM conference in Seoul. Most people will agree that MRI is an amazing imaging technology and that there has been a tremendous progress over the last years. However, a remaining problem is that MRI is still quite sensitive to patient motion. So for example, abdominal scans have to be performed during a breath hold, and a problem is that many patients are not able to perform this breath hold. And in this case, we get strong motion artifacts or ghosting artifacts, as you can see in this example here. And in this specific case, there's actually a lesion in the liver which is not visible anymore because of these motion artifacts. And therefore, in our group at NYU, we are working on new MRI techniques based on a radial data acquisition, which is more robust to patient motion. And if we use a radial acquisition in this specific patient here, we get this image quality where this lesion is now clearly visible. And so in this talk, I will speak about how radial sampling and also how compressed sensing can help us to improve the robustness of clinical MRI. And I will first give a basic introduction to radial case-based sampling, talk about the technical challenges and also about the imaging properties of radial sampling. Then I will talk about the StarVIBE sequence, which is the first radial product sequence available for clinical imaging. And here I will show a number of clinical examples from our experience with this sequence. Then I will talk about the GRASP method, which is an extension to the StarVIBE sequence, which enables us to use the StarVIBE sequence for dynamic contrast enhanced MRI in a very simple way. And also here I will show some first clinical results. And in the last part of this talk, I will give an outlook on a very new development, which is the XD-GRASP method, which additionally incorporates a motion compensation mechanism. And here I will show how we can use this XD-GRASP technique to improve the robustness of cardiac senior MRI. So let's first look at radial case-based sampling. What is radial case-based sampling? It's basically a very simple idea. Instead of sampling case-space row by row, as it is conventionally done, we sample case-space along these overlapping spokes, as you can see it in this animation here. And this is actually a very old idea, which has already been used by Paul Lauterbur in 1973. And if you remember this figure from his seminal MRI paper, it was actually radial case-based sampling that he described in his work. However, after the development of the phase encoding technique, or Cartesian Fourier MRI technique, radial sampling has never been used anymore very often, and in particular it has never been used for clinical routine applications. And the reason is that radial sampling has higher technical requirements. First of all, it requires a higher field homogeneity, which was a problem with the first or early MRI systems. Then it requires a very precise timing of the gradient fields, and also the image reconstruction is more sophisticated. So let's first take a look at this point, the image reconstruction. If we use a conventional Cartesian sampling, then the image reconstruction in MRI is a very simple procedure. To reconstruct an image, we just have to take our sampled rows, copy this data on a matrix, and then we calculate the two-dimensional fast Fourier transformation of this data. And this will directly give us the reconstructed image. So with Cartesian sampling, the image reconstruction is simple. Now the problem is, if we sample case-space along these spokes, then our sample points are not on an equidistant grid anymore. And you can see this in this figure on the left side. Our sample points are these yellow dots, and these yellow dots are now in between these grid positions. And therefore we cannot directly use a FFT algorithm for the image reconstruction. And therefore it's necessary to somehow first interpolate these data points onto neighboring grid positions before we can do a FFT reconstruction. And several years ago, an algorithm has been developed to do this, which is nowadays known as gridding or regridding, or some people also call it NUFFT. And how this gridding procedure basically works is we take our sample points, these yellow dots here, and we convolve or smear these sample points with an interpolation kernel, which is usually a Kaiser-Bessel function. And afterwards, we can take these smeared data points or smeared sample points and evaluate these smeared sample points at our desired grid positions. And after that, we can then continue to process the data using a normal FFT processing. Now, this gridding procedure actually comprises some additional steps like a density compensation and also a roll-off correction, but this is the basic idea how we can reconstruct images from radially sampled data. Now, to perform this gridding procedure, we of course have to know where our sample points are located in K-space. And the problem is that gradient systems never work 100% accurately. There are usually delays of the gradient fields, and this means that our sample points are shifted relative to the theoretical K-space position. Now, if we use a conventional Cartesian sampling, this is not a big problem, because in this case all our rows or sample points will be shifted in the same direction, and this does not have an impact on the reconstructed magnitude images. However, if we use a radial sampling, then we have different readout directions, and this means we will get a shift into different directions. And that means we will have a distortion of the trajectory. And therefore, we will get these bad image artifacts, which you can see on the bottom. Now, fortunately, the gradient systems of the recent MRI systems now have a quite predictable behavior, and therefore it was possible for us to develop a compensation mechanism. So prior to each scan, we perform a quick calibration scan, and with these calibration scans, we estimate these gradient delays. And we can then later use these gradient delays to correct the position of our sample points during the gridding procedure so that we get good image quality even in the presence of such gradient delays. And it turned out that this mechanism works quite reliably, and therefore it enables us now for the first time to use radial sampling for clinical routine applications. And why should we do that? What's the advantage of this radial sampling scheme? The key advantage of radial sampling is that it's much more robust to motion artifacts. And you can see this in this figure shown on the bottom of the slide. This is a liver scan which has been acquired during free breathing. And on the left side, a Cartesian sampling has been used. And in this case, you can see strong motion artifacts or respiration artifacts. And on the right side, the same sequence has been used with radial sampling, and in this case we still get acceptable image quality, although this was done during free breathing. So radial sampling is much more robust to motion artifacts. And there are two reasons why it is more robust. The first reason is that we have a oversampling of the K-space center, and this has a motion averaging effect. And the second reason is that we have different readout directions. So there's no direction where all spatial information is just encoded using phase offsets. And as you probably know, phase encoding is very sensitive to phase distortions and to motion. And in this case, we do not have a phase encoding axis. Another interesting property of this radial geometry is that we can perform readout oversampling in both directions. So what we can do is we can sample the data twice as fast, and in this case we get oversampling along the X direction and also along the Y direction. And this does not have an impact on the scan time, so it does not prolong our scans. And this is different from Cartesian sampling, because with Cartesian sampling we would have to acquire additional lines along the Y direction to get oversampling along this direction. And that means, in practice, if we use radial sampling, we can always make the field of view smaller than the object itself, and we will not get infolding or aliasing artifacts. Also very interesting is the undersampling behavior of radial sampling. And undersampling in this context means that we reduce the number of spokes. And because we can select the number of spokes independently from the base resolution, it's possible to select arbitrary undersampling factors. Now, for a fully sampled dataset, the number of spokes required is pi/2 times the base resolution. And it's not surprising that we get good image quality in this case, as shown in this image here. But if we only take 32% of the data, we still get a quite reasonable image. And even at 24%, the image quality is not that bad. If we now go to 16% of the data, we see some streak artifacts outside the object. At 12%, we get stronger streak artifacts, and we can now also see streak artifacts inside the object. And at 8%, the image quality is not really good anymore, but at least we can still see the object. And this image has been calculated without any parallel imaging. So radial undersampling creates these streak artifacts, which are kind of similar to the artifacts that we also see in CT imaging. And in my experience, people can quickly learn to read through these artifacts to a certain degree. And therefore, a certain level of streak artifacts and a certain level of undersampling is often accepted. And finally, another interesting property of radial sampling is that all the spokes go through the center of K-space. And this means we'll have a continuous acquisition of the K-space center information. Also, all the spokes are equally important. So there's no spoke that carries more important K-space information than another spoke. And that means a radial sampling gives a very balanced sampling of K-space. And therefore radial trajectories are perfectly suited if we want to have a continuous update of the image information, like in real-time imaging or angiography. And just as one example, this is a radial real-time movie which we acquired with a radial real-time sequence, and this is my colleague Graham Wiggins playing didgeridoo in the MRI scanner, which we acquired for the KSMRM in Australia. And so if you want to do such real-time imaging or real-time cardiac imaging, then radial trajectories are the perfect choice. And I will later talk about a radial cardiac imaging technique, but first I will talk about a different radial sequence which we developed together with Siemens Healthcare, which is the StarVIBE sequence. So the StarVIBE sequence is a radial version of the 3D VIBE sequence, and the StarVIBE sequence uses the so-called stack of star sampling scheme, which you can see in this figure. So in the XY plane, the sequence uses radial sampling, and along the Z direction, it uses Cartesian sampling. And this sequence is a fat-suppressed T1-weighted 3D gradient echo sequence, and therefore it can be used as a replacement for sequences like VIBE, FLASH, MP-RAGE, or T1-weighted TSE sequences. And the StarVIBE sequence works at 1.5 Tesla and also at 3 Tesla, and it will become available for Siemens MRI systems with the software version VE11. And over the last 2 years, we had the chance at NYU to evaluate the prototype of this sequence, which is also known as Radial VIBE. And we performed over 6,000 patient scans with this Radial VIBE sequence, with very positive feedback from our radiologists. And the key advantage of the sequence is that the StarVIBE sequence is much more robust to motion artifacts. And I will now go through a couple of clinical examples from our experience. And one of our key applications of this sequence is abdominal imaging. So in abdominal MRI, T1-weighted images are conventionally acquired during a breath-out of the patient. And this takes between 14 to 20 seconds, depending on the individual scan protocol. And if the patient is actually able to perform this breath-hold, then conventional breath-hold sequences deliver convincing image quality, as you can see on the left side. But the problem is that many patients are not able to hold the breath for such a long time, in particular sick patients or elderly patients. And in this case, we get strong image artifacts and we get an image quality as you can see it on the right side, where it's now quite difficult to identify small lesions in the liver. Now, if we use the StarVIBE sequence for this application instead and allow the patient to perform a shallow breathing, then we get this image quality. Now, this scan takes 60 seconds, so it takes significantly longer than a conventional breath hold scan, but in this case we do get diagnostic image quality although the patient was breathing. And this is a significant advantage for patients that are unable to perform a breath hold or where it's very likely that they will not be able to perform a breath hold. And we did a first clinical study to evaluate the clinical performance of this radial free breathing approach. And in this study, we looked at 18 patients, which were both scanned with a breath hold scan and then also with this radial free breathing approach. The images were then scored by radiologists blinded to the sequence information. And it turned out that we do not have to make a big compromise in image quality if we replace the conventional breath hold scans with this radial free breathing approach. And therefore, we started using this sequence routinely at NYU for pre- and post-contrast imaging in certain patient populations. And on this slide, you can see a couple of examples. And these scans have been done at 1.5 Tesla. So on top, this is a liver cirrhosis patient. And this patient was not able to perform a good breath hold. And so on the left side, you can see this attempted breath hold scan. And you can see there were a lot of motion artifacts. And on the right side, you can see what we get with a StarVIBE sequence in this patient. So in this case, we get significantly improved image quality. And what's important is that we can now see a lesion in the spleen, which was hardly visible on this attempted breath hold scan. On the bottom, you can see a patient with a tumor in the kidney. And also here, this tumor is much better visible on the StarVIBE free breathing scan because there are fewer respiration artifacts and also the spatial resolution is better. And this is actually a significant advantage of this free breathing approach because if we do not need a breath hold anymore, then we can of course go to much higher spatial resolution. So the achievable spatial resolution is not restricted anymore by the breath hold capability of the patient. And we can then go to base resolutions like 384. And on this slide, you can see a nice example that shows this advantage. So this is a patient who has a small clot or a thrombus in one of the liver vessels. And you can clearly see this on this radial high-resolution scan, which you can see on the right side. Now, if we look at this conventional breath hold scan on the left side, this thrombus is also somehow there if you look closely, but it's quite difficult to see it. And I would argue if you only have this attempted or this breath hold scan available, then it will be quite difficult or challenging to identify this clot. So it's really helpful in this case, or it was really helpful in this example, to get higher spatial resolution. And on the next slide, you can see two more examples for such high resolution scans. On top, this is a patient 20 minutes after injection of Eovist. And with the radial free breathing StarVIBE sequence, we can now push the spatial resolution to 1 millimeter isotropic, and we're getting significantly improved spatial resolution compared to what we can get with a breath hold scan, even in patients that are able to perform this breath hold. And this is simply because with these free breathing scan, we can then acquire data over multiple minutes if we want to. And on the bottom row, you can see an example from MR enterography. And also here we can get significantly higher spatial resolution and image quality than with conventional Cartesian sequences. Now another application where it is of course very beneficial to eliminate the need for a breath hold is pediatric imaging. And this is because pediatric patients usually cannot perform a breath hold at all, either because they are too young to understand what a breath hold is or because they are sedated. So on top you can see a 6-month-old baby. And this patient was not sedated, but of course too young to understand what a breath hold is. And on bottom, you can see a 9-year-old patient with tuberous sclerosis, and this patient was sedated during the exam. So in both cases, patients were breathing, and therefore Cartesian sequences are always affected by a certain degree of respiration artifacts. You can see this on the left side again. And therefore we get clearly improved image quality if we use the StarVIBE sequence for this application. So we get fewer artifacts, and also we're getting an improved effective spatial resolution. And you can appreciate this improved spatial resolution if you look at these small, tiny cysts in the kidneys of the patient with tuberous sclerosis, which now become visible in this StarVIBE free breathing scan. On the next slide, you can see two more examples. On top, this is a 6-year-old patient with a huge lesion in the chest. Again, respiration artifacts on the Cartesian scan and improved image quality on the StarVIBE sequence. And we are not only using this sequence for body imaging, we are also using it for pediatric brain imaging. And on the bottom, you can see a 4-day-old patient who was scanned because of a seizure. And on the left side, you can see that the Cartesian MP-RAGE scan was affected by quite significant motion artifacts. And with the StarVIBE sequence, we were then able to get reasonable image quality in this patient. And also for this application, we performed a clinical study to evaluate the improvement in image quality and also the improvement in diagnostic accuracy. And in this study, we looked at 73 patients who were scanned with both a Cartesian sequence and also with this radial StarVIBE sequence. And again, the images were evaluated by radiologists blinded to the sequence information. And the result of the study was first that the StarVIBE images received significantly higher image quality score. But this is not really surprising if you look at these images. But the more important finding was that in 15% of the cases, lesions were only identified on the StarVIBE sequence. And that means this radial sequence actually translates into a higher diagnostic accuracy. But of course, not only pediatric patients move, also adult patients move. And on this slide you can see a head scan of a 86-year-old patient. And again, on the Cartesian MP-RAGE sequence, which is visible on the left side, there were quite significant motion artifacts. And also in this application, we are consistently getting better image quality with the StarVIBE sequence. And therefore, the StarVIBE sequence has also become a routine protocol at NYU for imaging of the head and neck. And on the next slide, you can see two of our applications. On top, this is our neck protocol. And for this neck scan, for these neck scans, we are using a StarVIBE protocol with an isotropic resolution of 1 millimeter, so that we can create multiplanar reconstructions in any orientation. And this image quality, I think, looks quite promising. And what's important here is that you do not see visible swallowing artifacts, and there are also no visible pulsation artifacts. And in the bottom row, you can see our orbit protocol. In this case, the spatial resolution was even 0.8 millimeters isotropic. And in this case, you can nicely see the abnormal enhancement of the optic nerve on the right side. And this indicates that there's an optic nerve sheath meningioma. And what's important in this example here is that there are no visible artifacts from the eye motion. Eye motion is usually a problem in this application. The sequence works also very nice for imaging of the chest. In this case, you can see a 60-year-old patient who presented because of pain around the clavicle. And on the conventionally used turbospinaco sequence or turbospinaco protocol, there were significant respiration artifacts and also significant artifacts from blood flow due to the proximity to the heart. And with the StarVIBE sequence, we don't have these problems. And therefore, we were wondering, can we actually use this radial StarVIBE free breathing scan for diagnostic lung imaging? So can we use this sequence for detection of lung nodules? And therefore, we performed a clinical study. And in this clinical study, we looked at 32 patients where we had CT scans as a reference. And this allowed us to look at which nodules could be detected on these StarVIBE free breathing scans. And it turned out that we can quite reliably detect lung nodules that are larger than 5 millimeters, which is not too bad. But if the lung nodules are smaller than 5 millimeters, then the sensitivity for detecting these lung nodules on these free breathing scans is not that great anymore. And the problem here is that if the patient breathes, then the signal intensity of these tiny lung nodules is smudged out and becomes more difficult to identify or to pick up these lesions. However, there's also a respiratory gated version available of the sequence, and this is still a works in progress package which has been developed by Alto Stemmer at Siemens in Erlangen. And with this respiratory gated version of this StarVIBE sequence, we can then perform a free breathing scan which takes between 5 to 10 minutes depending on the respiration activity of the patient. And this will then give us a nice high-resolution scan, 3D high-resolution scan with an isotropic resolution of 1 millimeter. And on this slide, you can see such a high-resolution lung scan. This is patient data after contrast. And to me, the image quality looks quite promising. And what's interesting here is that we tried this also with Cartesian sampling. So we used the gated sequence with Cartesian sampling. And with Cartesian sampling, the sequence was not robust enough. And this can be seen on the slide here. On the left side, the sequence has been used with Cartesian sampling. And in the Cartesian case, you can see all these motion artifacts in the lung. And these artifacts are actually caused by cardiac motion and also by bowel motion. And with Cartesian sampling, these artifacts propagate along the phase encoding direction and they contaminate the low-intensity lung signal. And therefore, I believe that these high-resolution lung MRI applications will only work reliable with a radial K-space acquisition. Now, everything I showed so far can be done with this StarVIBE sequence. And as I said, the StarVIBE sequence will become available as a product sequence in a few months from now. And so if you want to use this sequence in your clinical practice, there are a couple of pitfalls. And so here are some hints or some tips. First of all, it's very important to disable coil elements that are far away from the region of interest, because these coil elements will only create artifacts. And you can see this in this figure on the left side. So in the lung, you can see a lot of streak artifacts. And these artifacts are actually caused by a coil element which sits close to the pelvis. And so if we disable this coil element, and this is what has been done on the right side, then these artifacts go away, and this does not have an impact on the signal intensity in our region of interest. So please disable coil elements that are far away from what you want to image. Now, a second point is that radial sampling has a different off-resonance behavior. And if we have fat tissue, or fat, then we get a signal blurring instead of a chemical shift. And you can see this here in this image on the left side in the second row. This is sort of an extreme example, but it gives an impression how the signal blurring can look like, and therefore it's currently necessary to use this sequence with fat suppression. And if we use fat suppression, we don't get these problems. And a final point, if you want to set up your protocols, instead of making the scan time as short as possible, it sometimes can make sense to acquire more spokes than strictly required, because if you acquire more spokes, then motion will average out and you will get less motion artifacts. So it can make sense to rethink your scan protocols towards a slightly longer scan time, but this will give a higher reliability of these scan protocols. Now, if you want to learn more about this sequence, there's an article in the 2013 RSNA edition of the Magnetom Flash magazine, and I recommend you to look into this article. You can download this article from the Siemens Healthcare homepage. And as I mentioned, this sequence will become available with the software version VE11. And I have to say that everything that I will show after this slide is not available as a product yet. These are still research projects. And this first research project, this is a collaboration with Li Feng, Ricardo Otazo, and Hersh Chandarana. Now, a certain drawback of these radial acquisitions is that the scan time takes somewhat longer. Now, for many clinical applications, this longer scan time is not a problem, but there are some applications where the slower scan speed is a problem. And one of these applications is dynamic liver imaging. So what's conventionally done in dynamic liver MRI is that we first acquire a pre-contrast image, then a gadolinium-based contrast agent is injected, and 20 seconds after the injection, we need an arterial phase image. And then 60 seconds after the injection, we also need a venous phase image. And then at a later time, we also want a delayed phase image. Now, getting the pre-contrast image and the delayed phase image with the StarVIBE sequence, that is not a problem. And this is basically what I showed in the previous section of this talk. But if a single free breathing scan with the StarVIBE sequence takes now around 60 seconds, it is of course a problem to get the arterial phase image and to get the venous phase image. So the StarVIBE sequence by itself is too slow to separate these two phases, to separate the arterial phase and the venous phase. And therefore we had to develop a solution, and the idea was, instead of doing these separate individual scans, we just perform one continuous scan, and while this continuous scan is running, we inject the contrast agent. And then after the acquisition, we can then take this continuously acquired data and we can perform a so-called compressed sensing reconstruction of this data. And what this compressed sensing reconstruction does, it basically gives us a time series of images, and this time series of images shows the tissue perfusion, and we can then simply pick those images out of the series that are clinically needed. And this is what we call the GRASP method or GRASP approach. Now, from a technical perspective, this GRASP method combines three technical components. First, it uses the golden angle ordering scheme. Then it uses a compressed sensing reconstruction, and it also incorporates or includes parallel imaging. So what is this golden angle ordering scheme? In the golden angle scheme, we always increase the angle of our radial acquisition by 111.25 degrees. And if we do that, what you can see is that the next spoke that we acquire will always fill the largest gap of the previously acquired spokes. So with each additional spoke that we acquire, we add complementary K-space information. And what you can also see is whatever number of spokes I take, so wherever I stop, we will always have a quite uniform coverage of K-space. And that means we can basically do one continuous scan, and we can then either take all the data, all the spokes, and reconstruct a single image from all the spokes, or we can take any subset of these spokes and reconstruct an image from a shorter time window. And we can select the width of this reconstruction window arbitrarily. And what we can also do is we can shift our reconstruction window arbitrarily in time. And that effectively means is we can do one continuous scan and we can retrospectively decide what temporal resolution we want to reconstruct and which image time points we want to reconstruct. And this golden angle scheme idea has been developed or has been described by Stefanie Winkelmann in this paper, which is listed on this slide. Now, if we select a short reconstruction window to get a high temporal resolution, we of course only have few spokes in our reconstruction window. And that means our data is strongly undersampled, and therefore we will get streak artifacts. And you can see this in the simulation here. So this simulation has been done with 13 spokes, and in this reconstruction from 13 spokes per frame, you can see all these strongly flickering streak artifacts. Now, on the other hand, we do know that the contrast uptake is actually a smooth process in the sense that we do know that it doesn't flicker. So if you look at the ground truth images on the left side, you can see that there are only very small and slight changes. So if we look at what is changing from time point to time point, and this is shown on the right side of this figure, you can see there are only very localized and very small changes, whereas in the undersampled case, we have all these highly flickering streak artifacts. And we kind of know that this flickering is an artifact because the contrast uptake is a smooth process. And therefore we can perform a so-called compressed sensing reconstruction, and this compressed sensing reconstruction is an iterative reconstruction which gives us a solution that matches to all our sampled spokes. But of course our sampled spokes are incomplete because we have undersampled data, and therefore it will give us this solution out of all possible solutions that has lowest flickering. And this makes sense because we know that our true solution does not flicker. And what we are technically doing here is we are doing a CG sense type reconstruction with a temporal total variation constraint. So we are penalizing or constraining flickering along the time domain. And in this way we can eliminate these flickering artifacts and we can recover the images without undersampling artifacts. Now, from a clinical perspective, the idea of a continuous data acquisition also has significant workflow advantages. Because if we have this continuous acquisition, we do not have to give a test bolus for a timing run. Then we do not need breath holding anymore because this grasp technique is based on a radial acquisition. And also there's no risk of a potential synchronization failure because in this case we are sampling data all the time and we can never miss the arterial or venous phase. And also, as mentioned, a nice feature is that we can retrospectively decide what temporal resolution we want to have. And on the next slide, you can see our current liver grasp protocol, or protocol for dynamic liver studies. And we are currently acquiring data for 120 seconds. And in this time, we are sampling 800 spokes. The contrast agent is injected 20 seconds after the start of the scan. And then in the reconstruction, we are combining 100 spokes into a single image. And this means we will get 8 images, and each image has a temporal resolution of 15 seconds. And this is then, of course, sufficient to fulfill the timing requirements of dynamic liver MRI. And in the figure, you can see some images. In the top row, these are conventional breath hold scans for the arterial phase and the venous phase. And in the bottom row, you can see the corresponding grasp images, which were acquired during free breathing, again for the arterial phase and venous phase. But what's really interesting about grasp is that we can take the same data and reconstruct this data set also at a different temporal resolution, because we can select the temporal resolution arbitrarily. And so if we combine only 13 spokes per frame into a single image, we will now get a temporal resolution of only 2 seconds per frame. And that means we will get perfusion information from the same data set. And in this figure, you can see such a perfusion reconstruction. Actually, in this case, the temporal resolution was even a bit higher. This was 1.5 seconds. And on top, you can see what we would get with a conventional gridding reconstruction. So if we only would use gridding for the image calculation, then we would get these images with these strongly flickering streak artifacts, these undersampling artifacts. And now in the bottom part of the figure of this video, you can see what we get with GRASP. And so with GRASP, we can eliminate these undersampling artifacts, and we get more or less artifact-free images from only 13 spokes per frame. And this is, of course, a 3D scan, so we're getting complete abdominal coverage. So the use of a compressed-sensing reconstruction enables us to compensate for the lower scan efficiency of radial sampling, and it enables us to use the StarVIBE sequence also for rapid dynamic contrast enhanced MRI, so that we get both fast imaging speed and also high motion robustness. Now, the first version of this GRASP reconstruction technique has been implemented in MATLAB. And if you're interested in testing this MATLAB source code, you can go to our homepage. You can see the URL on the slide, and you can download this MATLAB source code. However, a problem was that these compressed sensing reconstruction have a very high computational requirement because it's an iterative reconstruction. And with this first MATLAB implementation, the reconstructions took up to 6 hours per case. And this is, of course, much too long to use this technique for clinical applications. And therefore, last year, we worked a lot on developing a faster implementation. And this was work mainly done by Robert Grimm. And so the solution that we developed has 3 components. First, we developed a automatic raw data storage service software. And this software runs on all our clinical MRI systems. And this software will automatically send the case-based data from GRASP scans to a central reconstruction server. And we are currently using reconstruction servers with 64 CPU cores. And then on this 64-core CPU server, we then have a performance-optimized implementation of this GRASP algorithm. And this implementation has been written in C++, and it has been parallelized across slices. And this means we can reconstruct up to 64 slices in parallel. And with this parallelized reconstruction, the reconstruction time is now only between 5 to 45 minutes per case. And this software will create DICOM files. So finally, we can send these DICOM files into our PACS archive so that our radiologists can look at the images together with other scans for the patient at our normal PACS workstations. And what they can also do is they can send the GRASP images to another post-processing software like Osiris or DynaCAD. And so with this setup, we now have a solution available that allows us to maintain our standard clinical workflow. And so this enables us to really test this GRASP technique in clinical patients. And we've already performed over 1,400 patient scans with this GRASP technique. And I will now go through a couple of examples. And this first example is again a dynamic liver scan, a free-breathing GRASP liver scan. And in this case, it was again a pediatric patient. So this was a 9-year-old patient with tuberous sclerosis. And in this movie, you can see the image quality that we get with GRASP in this application. And what's interesting about this case is that this patient has a small focal nodular hyperplasia in the liver, which is a benign tumor. And this FNH tumor is only visible in the arterial phase. So it's not visible prior to the contrast injection, and it's also not visible in the later phases of the acquisition. So it's only visible in the arterial phase. Now, a FNH is a benign tumor, but there are also malignant tumors which enhance in the arterial phase, and therefore it's very important to get a precise timing and to get fast temporal resolution. And so with the GRASP technique, we can get a temporal resolution of up to 2.5 seconds per frame in this application. And what we can then also do is we can draw region of interests and create signal intensity time curves, which you can see on the right side. And in these signal intensity curves, you can again objectively see this early enhancement of this FNH lesion. And what we can, of course, also do is we can take these perfusion images and do tracer kinetic modeling. Now, of course, we can not only use the GRASP technique for liver imaging. It's a generic dynamic imaging technique, and so we can use it for any other dynamic imaging application as well. And actually, the largest portion of GRASP scans so far has been done in the prostate. And so in the prostate, we can now get a spatial resolution of 1 by 1 millimeter with a temporal resolution of 2.2 seconds per frame. And on the right side, you can see how these dynamic GRASP prostate scans look like. And compared to our previous dynamic prostate protocol, this is a significant improvement in image quality and spatial resolution. And you can see this in these subtraction images shown on the left side. So on the left side, this is the image quality that we got with our previous flash-based protocol. And then on the right side, you can see what we get, or what spatial resolution we can get with the grasp technique. And you can clearly see that we get much sharper images in this case. And therefore, the grasp technique has now become the routine technique for dynamic prostate MRI at NYU, and we have already performed over 500 clinical patient scans with the technique. And just to give you an impression why it is so important to get high spatial resolution, or why it is helpful for us to improve the spatial resolution, here's a case. This is a 63-year-old patient on active surveillance, and on these dynamic grasp scans, they found a tiny lesion in the peripheral zone of the prostate, which shows a very fast uptake of the contrast agent and then also a very fast washout. You can see this lesion that's indicated by this yellow arrow. So quickly after the contrast injection, you can see now this lesion, and then short time after, it already disappears and then it's becoming invisible, which means the contrast is washing out quickly. And you can also clearly see this lesion on the washout map, which has been calculated from the grasp images. The washout map is shown on the right side. Now, this tiny lesion also had a decreased T2 value and a decreased ADC value, and actually on a biopsy, then there was actually a tumor found in this region of the prostate. So it's really helpful to get higher spatial resolution in these patients. Now, another application where we started using grasp routinely is dynamic imaging of the pituitary gland. Now, the pituitary gland is a small organ or a gland located at the bottom of the brain. It's indicated by this yellow arrow in this on the right side, in the movie on the right side. And this is a quite common site for mainly benign lesions like adenomas or cysts. And these lesions have an abnormal contrast uptake behavior. And therefore, it is again important to get dynamic image information. And so on the right side, you can again see how these dynamic grasp scans look like. Previously, we used 2D TSE sequences for this application. And now with the grasp technique, we can get much higher spatial resolution, especially along the slice direction, so we can get much thinner slices. And in addition to that, we can also get fat suppression, which we couldn't get with our old 2D TSE protocol, and our radiologists like fat suppression in this application. And also here we've meanwhile done over 400 patient scans. And just to give an impression how these pathologies look like that we are interested in, here are two cases. So on the left side, you can see a well-defined lesion in the pituitary gland, and this lesion does not enhance. So if we look at these signal time curves, we can see that the normal pituitary gland shows a clear contrast uptake and also a certain washout. So this is indicated by the green curve. And if we then draw a region of interest into this lesion, we can see that there is no contrast uptake at all. So this is very likely a cyst. Now on the right side, you again see a pretty well-defined lesion, but this lesion shows a clear but delayed uptake of the contrast agent. So if we again look into the signal intensity curve, we can see that there is a delayed but a clear uptake of this contrast agent, and therefore this is very likely an adenoma. And this is actually a rather large adenoma. Many adenomas are much smaller, so-called microadenomas, and therefore it's again very helpful to get high spatial resolution, and this is why our radiologists like the grasp technique for this application. Now, these were the first applications where we started using grasp routinely for diagnostic purpose, and then there are of course many interesting research applications. And on this slide, you can just see 3 random applications that we're currently looking into. So we started using grasp for dynamic imaging of Crohn's disease, which might be a promising way for an early treatment monitoring. Then we are looking into perfusion of tumors. In this case, on the top right, you can see an orbit tumor, and this is a difficult location for MRI. But as you can see with the grasp technique, we get quite reasonable image quality without visible motion artifacts. And of course, then there's the whole field of permeability mapping of brain tumors, and we just started looking into this field, but this shows the image quality that we can get in this application. Now, of course, it is always a bit problematic if only a single research site does the evaluation of such a new imaging technique. And therefore we also created a collaboration network, so far with 6 international sites, which you can see on the slide here. And all these GRASP collaboration sites invested into such an offline reconstruction server, and they have an installation of the GRASP software. And they are now independently evaluating the GRASP technique in their own research studies. And in addition to that, we are also performing a joint multi-institutional study on the performance of free breathing dynamic liver imaging with over 400 clinical patients. And this is very exciting to us, and I think this is also a very important step in validating and proving the actual clinical value and stability of this GRASP technique. But of course, we do not want to stop here. In parallel, we are continuing to improve the technique. And one problem that we still have sometimes with GRASP is in patients that perform a very strong and very deep breathing during the data acquisition. And you can see such an example on this slide here. This is a patient that we scanned some time ago, and here we were not really happy with the image quality. The image quality is not totally bad, but especially the arterial phase is not clean. So what happened here? And you can clearly see this if we look at multiplanar reconstructions, which we can create from these images. And in these multiplanar reconstructions, you can see that in the moment when the contrast was injected, the patient started to cough. And so the liver was moving up and down by around 10 centimeters. And this is, of course, a problem. Because the radial technique, the radial sampling, does not show these typical motion artifacts. But of course, radial sampling by itself cannot prevent data inconsistencies caused by different motion states. However, with a radial acquisition, we have a continuous acquisition of the K-space center information. And therefore, the radial data also contains information about the respiration that occurred during the acquisition. So that information is inherently embedded into our data. And you can see this in this projection view, which you can see on the right bottom side. Basically, each stack of spokes for each angle gives us a projection through the patient. And if we display these projections along time, then we get such a projection view. And in this projection view, you can actually see how the patient is breathing. So you can see how the liver is moving up and down. And it's also possible to extract a respiration curve from this data. And this is simply possible by plotting the K-space signal intensity whenever we go through the center of K-space. So basically, if we plot the signal intensity whenever we hit this red dot, which you can see in this figure on the top side, we get such a respiration curve, which you can see on the left side. And this respiration curve basically tells us when and how the patient was breathing. And we can actually use this information to correct for such data inconsistencies. And this is a concept known as self-navigation. And if you again look at this projection view, you can see that this projection view not only contains information about the respiration, but you can also see the cardiac motion. And so in this last part of this talk, I will talk about how we can combine this self-navigation idea or self-navigation concept with our GRASP reconstruction technique for the application of cardiac senior MRI. And this is again a project done by Li Feng, Ricardo Otazo, and Leon Axel. Now for this cardiac application, we are not using the StarVIBE sequence. In this application, we are using a radial 2D SSFP sequence, so a true FISP sequence. And this sequence is again using the golden angle scheme. Now with this 2D sequence, it's now possible to in parallel detect both the respiratory motion and the cardiac motion. And we can do this by looking at the K-space center signal from different coil elements. Now to get the respiratory motion information, we look at a coil element which is located above the tip of the liver. So signal changes that we see in this coil are mainly caused by respiratory motion. So this will give us a respiratory curve or breathing curve. And to get the cardiac information, we then look at a different coil element, a coil element which is located above the heart. So signal changes that we see here at the K-space center are mainly caused by the contraction of the heart. And so in this way, we get two different motion curves, a respiratory signal and a cardiac signal, both from the same acquisition in parallel to the image data. And of course, these curves are usually noisy, so we need some kind of a clever temporal filtering. And then we can take these two curves and we can bin them into different motion states. So we can bin the respiratory signal into different respiration states, ranging from expiration to inspiration, and we can bin the cardiac states into cardiac states from diastolic phase to systolic phase. So this gives us different respiratory states and cardiac states. And now what we then can do is we can take our sequentially acquired spokes and assign a parametric state to each of these spokes. So for each spoke we can tell what the respiratory state was and what the cardiac state was. And we combine these respiratory state information, cardiac state information into a parametric state. Then we can take these sequentially acquired spokes and we can sort them according to their respiratory and cardiac state. And this will give us a different set of many different parametric frames. And these parametric frames each contain to a different combination of a respiratory state and a cardiac state. So we basically get case-based data for many different parametric states. But of course this data is undersampled because we do not have enough data for all these different combinations of respiratory and cardiac states. And therefore it makes again sense to use compressed sensing. But in this case we are not using compressed sensing along the time domain. In this case we are applying compressed sensing along these new parametric dimensions, the cardiac dimension and the respiratory dimension. And this is what we call XD grasp, which stands for extra dimensional grasp. So once again, in the normal grasp method that we discussed in the last part of the talk, we are using compressed sensing along time. So we are searching for a solution that matches to all data and that has lowest flickering along time. Now in XD grasp, we are searching for a solution that again matches to all the spokes, but this solution now should have lowest flickering along the respiratory states and along the cardiac states. And in this way, it's then possible to remove these undersampling artifacts, these streak artifacts again, and to recover these many different parametric frames without undersampling artifacts. And on the next slide, you can see some first results. This is volunteer data, so a scan of a healthy volunteer, and this scan has been done during free breathing without any ECG gating. And again, the sequence here was a radial 2D SSFP sequence. And on the left side, you can see the result that we get with a normal grasp reconstruction. And that's actually not too bad, but we can still see some flickering artifacts here. And what you can also see is that the patient is breathing, so there are different respiration states. Now on the right side, you can see what we can get with XD grasp. And with XD grasp, we now have these different additional parametric dimensions. And this allows us now to look at the data at a certain respiratory state. And in this way, we can kind of virtually freeze the respiratory motion. So we can acquire the data during free breathing, and then after the reconstruction, we can freeze the respiratory motion by looking at the data at a certain respiratory state. And as you can see on the right side, there's no visible respiration anymore. And this is, of course, highly interesting for clinical patients because conventional cardiac senior MRI has to be acquired during a breath hold. And it's again the same story. If the patient is not able to perform this breath hold, then we get strong motion artifacts, as you can see in the middle here. And with XD grasp, as I mentioned, we can just acquire the data during free breathing and then in the reconstruction virtually freeze the respiration. Now XD grasp is also very promising for patients with arrhythmia because ECG-gated imaging often fails in patients with arrhythmia. As you can see here, in this case, this is a patient with premature ventricular contraction. Now, since we extract or generate the cardiac information from the data itself, and we are not relying on an external ECG signal or on a prediction from an ECG signal, we don't get these artifacts in this case. And so we get pretty reliable image quality with XD grasp. And on the next slide, you can see another patient. This is a different kind of arrhythmia. This is second-degree AV block, where individual heartbeats are missed. And again, in this case, we get artifact-free images with the XD grasp method, not only in a short axis view, but also in different orientations, like this 4-chamber view shown on the bottom. Now, since we have these new parametric dimensions, we can also do completely new things. So instead of freezing the respiratory motion, we can also freeze the cardiac motion. And this enables us to look at what happens to the heart, or how is the heart deformed when the patient is breathing. And this is shown on this slide here in this video for different cardiac states. So all these images correspond to different cardiac states, and we are now looking to what happens to the heart when the patient is breathing. And what's especially interesting here is that you can see a deformation or motion of the interventricular septum. So the interventricular septum is the structure which is indicated in yellow color on this figure on the right side. And especially in the diastolic phase, which is shown in the first row of this movie, you can see that this interventricular septum is moving back and forth, and it's sort of deformed. And this is again shown on the next slide for different degrees of breathing. On the left side, you can see a normal breathing, and on the right side, you can see a very deep breathing. And you can see that there's a quite substantial deformation of this interventricular septum, especially in the diastolic phase. And this was a healthy volunteer without any condition. And so this technique potentially might help us to better understand the interaction between the left and right ventricle, and it potentially might also give important information or helpful information in the investigation of diseases like pericarditis. Now this was done with a 2D sequence, and can we also use this XD grasp idea for our 3D StarVIBE sequence? And the answer is yes, this works as well. And on this slide you can see a first proof of principle volunteer scan without any contrast. And in this case, the XD grasp technique has been used to bin the data into 20 different respiratory phases and then to recover these respiration phases. And on the next slide, you can see results of this motion compensated XD grasp reconstruction. And as you can see, in comparison to a reconstruction without any correction, which is shown on the left side, there is a significant reduction of these data inconsistencies and a significant improvement of the image sharpness. Now this was a scan without any contrast injection, so this was not a dynamic scan but a static scan. And in the next step we are now working on applying this XD grasp idea for dynamic contrast enhanced imaging. And I think that this will then be the solution for these remaining problems that we sometimes still see in grasp with patients that perform a very strong breathing during the data acquisition. To quickly summarize this presentation, radial sampling has a long history, but now it's reliable enough for clinical routine applications. And the key advantage of radial sampling is that it's much more robust to patient motion, and therefore it can be an interesting option for applications where motion is a common problem, such as abdominal imaging of patients that have difficulties to perform a breath hold. The first radial product sequence, the StarVIBE sequence, will become available with the next Siemens software version, the version VE11, and this will be released in the next month. Now, if you want to do dynamic imaging with the StarVIBE sequence or with other radial sequences, then the compress sensing based grasp method is a potential solution, which gives dynamic information from a continuous acquisition. And an interesting feature is that we can select the desired temporal resolution after the scan. The grasp technique is also very promising for applications with a lot of motion, especially for patients that have difficulties to perform a breath hold, such as elderly patients or pediatric patients. And the reconstruction time that we are now achieving with our fast implementation is already sufficient to use this technique for first clinical evaluation studies. Grasp can also be combined with an additional motion compensation mechanism, which we call XD grasp. And as I just showed you, this XD grasp technique allows us to do cardiac MRI during free breathing without any ECG gating, and therefore it can also help us to improve the reliability of clinical cardiac MRI. Now, the work that I showed in this presentation was a highly collaborative effort, and many people contributed significantly to this work, which are acknowledged on the slide. And I want to in particular mention Li Feng, Ricardo Otazo, Hershan Narana, Robert Grimm, Leon Axel, and Christian Geppert. So thanks for watching this presentation. If you want to learn more about these techniques, you might visit our homepage at care.net. You can see the URL on the slide, and you will also find my contact information. Thank you for watching.